So we can do this even when the buccal plate is missing and be minimally invasive. Now, you don't always get 100% buccal dimension change. The data that we have is about 1.3 millimeters buccal lingual change. So is this perfect? No. There is about a 1.3 millimeter change. But if you don't have enough bone to do this, when you go back in 4 months, 4 to 6 months, what you do is you can add at that point, and that's what we do. So I think that, this will give you some ideas, I'm sorry, as to where we want to go. When we go in and open this up, let me show you this case here. We do see, when we go in and take this case here, we've got a fractured tooth here. We're going to take it out. As you see here, it's fractured. We're going to take it out, but the buccal plate was partly missing. Do the ice cream cone technique. And we tack it, in this case, with some rib-on material, just a little pontic with a little rib-on, in this case. This is what it looks like. We go back in 4 months, and you see there is tissue here, right there. So if there's not enough, we can add more bone to it now. So this is what we do with these cases. And now we do the same as I showed you before. We wind up attaching this crown to the shell that we have. Just connect it in any way we can, connect the two, take it out, and it looks like this. Is that what you put in? Of course not. Well, I have to ask, but I mean, you should see what I see. I see stuff like that all the time. You can't believe some of the things that I see. And I'm sure some of the other specialists in the room see it too. This is what you put in. Take the time to do that. Put that in there. Let the tissue adapt to that, as you see here. Then your tissue is already sculpted. Now your case is done. You don't have to do pressure, nothing. Just fill up the two, and there's your final case, and there's your case in place, with no buccal plate, and there's the final crown. Now, we've done this Jocelyn Tan. We've sent this in for, we've done 11 now, and the average buccal lingual dimension change compared to what the contralateral tooth was 1.3 millimeters. So it's not perfect, but at least it gives you a great head start, and in most cases it's enough to reform the bone. If it's not, you just add more when you place the implant. At least now you have bone to put it into. So here's probably the best thing, if you haven't seen this, the best way to take a tooth out. And that is, you need different instruments. You got piezos, of course. You got periotomes. And this, to me, is the fastest, easiest way that I do it. This is a very long tapered diamond. Brasileir makes this. It's not my burr. I don't have any rights to it or anything like that. It's a surgical length shank, so it's so that it won't get hit. If you have to go after a root tip, this doesn't get stopped by the incisal edges of the adjacent teeth. So it's an 859 surgical length burr by Brasileir, and you can maybe find it with others. I just find that this one works well. Now, this little thing that I'm just showing you here is critical. I used to go buccolingual, mesial-distal for all these teeth. I now section these buccolingually if I break off the anterior tooth. Why? For bicuspids, go mesial-distal. There's 2 roots, of course. But and molars, we hemisect and trisect before we put a forceps on. But why do I go this way? What I used to do is go across here, see, and then just try to separate and get the palatal root out. But in trying to do that, the buccal was constantly getting pushed and flexed. And you see a lot of you shaking your head, we've all been there. If you do this, and you go into the ligament space around the side with that diamond stone, when you move this apart and you tell the patient you'll hear a crack, this is not put pressure on. You don't see you put your finger there, you feel almost no pressure on the buccal plate. And one of the pieces breaks off, and then you can take it from there and take it out. So this was the day that, unfortunately, this is a new patient. The patient doesn't have a clean mouth. But let's take a look at this. This is the day that we just were able to video this. So we're going to take this root tip out. Intracircular incisions, take the root tip out. Obviously the classic breaking off. This is so typical, right? Now we're going to go in, and in this case we're going to divide it, go back and reiterate, now that the crown's off, go back and do an intracircular incision. Here, look at how long the diamond is, you see? Now it goes in, and you go a little bit into proximally and palatally, but then this is the key thing, divide it down. Then with elevators, you move mesial and distally now. You break one of the pieces off, will come off, is a long rondure, and just take out the piece that's broken. The root tip is still in touch with this, but now I can move that mesial distally, and then the whole root comes out. So the key is to get atraumatically, to get this out, and that's what we did here. Now we're going to be able to clean that out really well and make sure that it's thoroughly debrided. As you see there, check your buccal plate. Make sure you go in and start cleaning this. And now the drilling. Now I'm using my palatal, the cingulum as my guide. So I'm going in. I start with a sharp burr up the palatal root. And here's the tapered drills, 3-eyes tapered drills. I'm using, again, the palatal root, not the incisor ledge, this is my guide. And this is the blue, this is a 4mm drill going wider. In this case, we're going to go to 5 and platform down to 4. So we have a platform switch, and there you see the drilling. And then this is the tapered implant, full osteotype, coated to the top. And you watch how this will prevail, and you see it bind. Look at where it binds. That's amazing. Look at where that binds, especially the 5s. They really bind well, and then the rest you can ratchet down. And it's really nice. Now, you can't do this with some implant companies. Some you can't go past 65. You do that with the Nobel, you'll rip the top off. I'm serious. That's one of the real serious consequences. But here you replace it. You got markers on here to know how deep you're going, and there's the implant placed, okay? So we're ready to go. What do we do with molars? What do we do with molars? Do I put a forceps on that tooth? No way. No way. I just don't grab a forceps and try it out and see if it comes out. Okay? No way. There are two burrs placed every time I'm ready to do an extraction by my assistants. First burr, a cross-cut fissure burr, something that cuts through bone, and not bone, through crowns and through teeth real well, like a 558, just boom, something real fast. The other one is that long diamond I just showed you. So this is with the cross-cut fissure burr, whatever burr you like, really cutting through fast, including cutting crowns off. Then I'll go in with that diamond stone, and I'll go like as if I'm prepping the tooth. I'll go down the ligament space here, around here, and then separate the 3 roots separately, and they come right out. And that's the way we do it. I do not put a forceps and start buccolingually rocking this tooth out. So then you notice this comes out. After lunch, we'll talk about the gap distance and how my whole philosophy has changed about dealing with molars now. It's completely changed. And we have a subclassification for sockets, which I'll show you later. So, if you talk about immediate placement, there's another way to do this. Immediate placement is obviously when type 1 defects only. Type 2 defects, some people do early placement. Danny Boozer certainly is a big prominent person that is a great clinician, superb surgeon, and has lectured and written a lot about early placement, really 4 to 8 weeks. Now it's more like 6 to 8. Now what happens if you wait early, if you don't put it in immediately? Now he doesn't like doing any immediates. Now I disagree with that now, and I have the data to show that we can do immediates when the buccal plate is present. I just go right to it. So I think we just support the tissue and everything right away. He doesn't want to do any immediates. What he does, no matter type 1 or type 2 or type 3, what does he do? He does delayed. He'll wait 6 to 8 weeks. Now, by doing that, he's a smart guy. What does he get? If you wait 6 to 8 weeks, what did you get back? You get soft tissue back. Maybe some osteoid in the middle, but really you got soft tissue. Nature gave you the soft tissue back. It's at 8 weeks, it's covered over, the soft tissue's covered back. Even if there's no bone, and even if you lose some of the shape, you have soft tissue. So that's what's clever about it. And then he goes in and does a surgery. And it looks a little bit like this. Now, delayed is, as you'll see, I do with molars. And you'll see why I do that. If I don't have the buccal plates, I'll do that with molars. You'll see why 4 to 6 weeks is not enough. And this is what Danny does. He does what's called a remote incision. There'll be a depression here where he let it collapse in. So he does nothing, no grafting, nothing at the time of extraction. Let nature just get rid of any infection, let it collapse in if it wants to, and that's it. And that's fine. Then he'll place the implant. Like we discussed, we're all on the same page. 3 millimeters up, 2 millimeters back. That's about the going rate these days with everybody. Now then he's going to take some autogenous bone from the nasal spine. He'll take some bio-os and bio-os collagen to cover the top to give it some shape, and then he'll put BioGuide or a membrane over the top. And then he'll close it. Now what's right and wrong about that? The good news, he has soft tissue to cover his defect easily. What's the negative about this? He just did a magnificent paper in the Journal of Periodontology of 1 and 3 year data on 20 consecutive cases. One of the finest clinical papers I've ever seen documented. And what did he show? He showed that buccally, when he looked at the Furhauser index with a cosmetic index, his buccal, 19 out of 20, looked great, meaning the shape looked good. So his grafting worked by doing this on the buccal. But what did he also show? It's a small line in the paper. He he lost his papilla, or his papilla weren't present 50% of the time. 50% they were not complete. Now, for single tooth implants, they usually come back if the adjacent bone is good. So he had 50%, he didn't have a full papilla. And why? One of the reasons maybe is that he opened the papilla up to do the surgery. So I like the idea as an alternative to the ice cream cone, if everything's there. I don't want to open the papilla up. So what's the alternative? Do a papilla-sparing surgical technique. And that's what we do routinely. This is what happens sometimes when you don't do a papilla-sparing technique. This is Mike, and take a look at this. He's general dentist. He actually comes from Florida. His general dentist sent me this as the pre-op that he had, and he fractured his tooth. And he found some guru online, and there's the fractured tooth right there. And he found some guru in Pittsburgh somewhere, and he took the tooth out, and that doesn't look so bad. Then he came back and did the surgery. Look at this. He was able to get this picture because the patient came to him and said, I'm in pain and this and that, and the guy didn't know what he was doing. He placed an implant, didn't know how to graft it, didn't know how to do anything here, and this is what he did, too close to the adjacent tooth. I mean, there's so many violations here, and this, unfortunately, this is when I saw the guy, he looked like this. This is what he walked in with it, even though he had a normal architecture and just needed one tooth taken out. So opening flaps have their risk. This is about as bad as I've ever seen from one surgery. This is terrible. When he had bone there, too. So this is what we do. We do remote incisions. We leave the papilla alone if it's there. Do not disturb, do not touch. We do remote incisions and come out. This is from Tony Sklar's book, which is a very nice book, but he didn't devise this technique. This has been around for 30, 40 years. But it's a nice diagram from his book, and he's obviously a fine surgeon. I'm sure most of you know Tony. And so this is a good diagram to show what to do. If it's there, leave it there. And then as an example of that, I'll show you this case where you see the depression here, and we're going to do papilla sparing technique. This patient already is short papilla from wearing a bonded bridge for most of his childhood, and now I don't want to disturb that. If I don't disturb it, it's not going to go anywhere. It means a little more work on my part, meaning access-wise. So I go in, and here's the depression, place the implant. See, this is what I want to see. Tissue, undisturbed, and don't have your assistant poke it either. Your assistants are not used to being delicate with their probe, so they go, like suction. They've got to learn to suction anywhere but here. They don't poke that, and they must be taught that too. So I put the implant in. This is a 325 micro mini. In this case, I just had this defect here, so I put a membrane in, put some graft in, as you see here, and then closed it. It was pretty straightforward. Did that on both sides. You see the big depression on the other side from congenitally missing tooth. But this papilla sparing, and that's what I like. Place the implants in, fine-tuned this one, got it in okay, and here's the final aesthetic outcome, and you can see that this is doing quite well. Now, you see that there's a little line here, you say, but I don't like those grooves, I don't like those scars. I don't like scars. See the scars? Well, this patient didn't even see that. See it here? It's very, very light. But I haven't lost the papilla. That's what I love about this. So the risk of if the papilla is there, it's not going to go anywhere if I don't disturb it. So is it really a scar? The answer is no, it's not a scar. It's a groove, but it's not a scar. Why is it not a scar? Gingiva doesn't scar. Everybody calls it a scar. But gingiva doesn't scar. It's not like skin. Why doesn't it scar? Anybody? Why doesn't a gingiva scar? If I do a gingivectomy, well, I know you're perfect, Nelson, but let's say I do, we've established that earlier. I do a gingivectomy on Nelson right now, and I come back in 2 months. Do I see any scars? You see a scar after a gingivectomy? You just lopped off a whole bunch of tissue, right? And then I come back in 2 months. Do I see a scar? You don't, do you? Am I missing something? The answer is no, right? You don't see a scar. Why? Now, plastic surgeons, they spend 10 years of their life learning how to fix scars and not to make a scar or minimize it. That's because they deal with skin. Why is gingiva not like skin? No, it's not the turnover rate. It's not far off from the same. What is gingiva missing that skin has? No, they're both keratinized. Elastic fibers. Elastic fibers. So there's no elastic fibers in gingiva, where there is in skin, and certainly in mucosa there's elastic fibers, but not in the gingiva. So when we see a scar, it's because of lack of adaptation of the two parts, and there's a groove, but it's not really a scar. So if we leave it open to heal, then you'll see this bigger scar. But if you get good adaptation, you don't hardly see any scar, and it usually goes away. The worst that happens is what? if the patient was bothered by that little line, like right here, if the patient was bothered by that in any way, what would I do? First, I would say give it a couple of months or give it 6, 8 weeks, let it adapt. But if it still bothers the patient, what do I do? Just take a large diamond stone and plaster it flat, and there's no scar. Just flatten the hole down a little bit, and it re-epithelializes, and you're done. A week or two later, you don't even see anything. I'd rather do with that anytime than what? A papilla missing, like I showed you in the previous case. Then you got to do forced eruption. You got to do all kinds of stuff to bring the papilla down. Got it? So this is what we do. So there's the final aesthetic outcome there. So the other thing is type 3 cases. So what we do here, this is type 3, the buccal plate and the soft tissue are missing. And so this is a good example of what we like to see. We'll take this out. This was not a big aesthetic case, but I showed you how to do this. Now, this is beautiful. Now, this is great because the palatal tissue's there. So that's what's beautiful about this. Is like doing the boozer, waiting 8 weeks is great because this palatal tissue, the tissue is going to fill in here. Let nature, don't go crazy grafting this. Let nature get rid of the infection. Let nature do this for you. And what's it going to do? Nature's going to give you the most beautiful free connective tissue graft you ever saw. Let's watch. Look at that. Even in 1 week, it's starting to close over. It's not fully closed until about 3 weeks, but it's starting to close in. Yeah, it's going to collapse in. There's no bone there. There's no tissue. But it's giving you soft tissue back. At 3 weeks, you can see it's granulating in, too. So in this case, we waited 10 weeks, and look at what nature gave us. It's collapsed in, but I have soft tissue now. And so what am I going to do? We're going to do a papilla-sparing technique. Go and leave the papilla alone. There's the defect. Place the implant. You'll have some dehiscence. Free up the flap. There's a membrane that you see here. I suture the membrane to the palate so that it opens up. I'm going to be about 3 to 5 more minutes. I open it up. You see how I pull this down, one suture to stabilize it after I've trimmed it. I open it up and see it hanging here by this suture so it doesn't go anywhere. Place the graft. This is the full osteotype. Place the graft as you see here. Plaque it down and then flip it back over. And nothing else. That's all you need to stabilize it. And then do your suturing. And there's the final radiograph. And then just do your suturing. And this is how things work. And that's what we should be looking at. So this is just another one that we don't have to show another one. So I just wanted you to get you, 1 second here. Hold on. Okay. So let's do the summation for lunch. Where am I today? Type 1 socket. Buccal plate present, soft tissue present, everything's there. Whether it be thick, flat, or thin scalloped. Either one now, I'm doing yes. This used to be a question mark. But the thin scallop, now I'm realizing that we're seeing, I'm not disturbing it as much. I'm not disturbing it at all. I'm faking the tissue out to think that the tooth never left. So this, instead of letting it heal and then regenerating the papilla back, we're finding that the best result is where we leave everything intact, put with type 1, and we put the implant in the same day. Don't even let everything collapse in. Type 2 or type 3, type 2 you can do the ice cream cone technique, or for type 2 and type 3, do the Boozer technique. But what do I suggest a modification of the Boozer technique? No remote incision, papilla sparing incision, wait the 8 weeks and do it. Now for molars, 6 to 8 weeks is not enough for molars. Although the soft tissue will change, why do I wait longer? I don't do the Boozer technique in the molars because there's not enough apical bone to grab. See, 6 to 8 weeks is okay for Boozer to go in or for you or I to go in. The soft tissue will have closed over, but he doesn't care about the bone because he's got apical bone to lock into in the 6 or 8 anterior teeth. In the molars, we have a different problem. We can't go apically because of the nerve or the sinus. Maybe sometimes you can, but most of the time you can't. So that's a whole separate problem. And so we want to give what? Why do I wait 3 months? I do not graft sockets immediately in the molars. This is against what some of you have been taught to do. Oh, let's stop it from collapsing in and doing a big graft at the time of extraction. Pull the flap over the top, and the patient's got the cheek pulled all the way over the top of the ridge. No, 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 no. Take out the infected tooth. Clean out the defect. Let it collapse in any way it wants. Give it 3 months, though. What happens in that time? Soft tissue will cover over, of course, in 2 to 3 months easily. But now we're getting, at 3 months, we're getting some new osteoid and young bone at the bottom part of the socket. Enough for us to hopefully lock in the implant to 3 months. Then we do all the grafting at that point. It's more comfortable for the patient. The nature is giving you the soft tissue back. So at 3 months, you go into the molars, place it into whatever bone you have. Now you have clean incisions, keratinized tissue everywhere. You're not pulling mucosa all the way over like it's at the extraction time. And it's more comfortable for everybody. Infection's gone. Your bone is filled into a great degree, and your soft tissue is completely over the top with plenty of keratinized tissue. Make your incision, then you can free that up and get your bone graft in to whatever dehiscence you have. But at least you got some bone to lock into. Then you can graft. All the grafting is done at that time at 3 months, not at 6 weeks. Anteriors, you go in 6 to 8 weeks. Why? Because the apical bone is already there, but you don't have that option in the molars. Whew. Last piece. When we do look at the bone zone, look at where we are with these numbers. And this is the new stuff. Just putting an implant in, looking at 3 millimeters to 9 millimeters up, the bone zone. When we just put an implant in with a healing abutment, and this is type 1 defects only, not even a temporary, what do we see? Buccolingual dimension change at 3 millimeters up of 1 millimeter. Just exactly what Uli Grunder showed. Not 4 millimeters. This is no flaps, just putting an implant in. When we put a temporary on, we see that maybe a 0.8 different ridge change is only about 0.8. Look at this. When we put a bone graft in, and we'll go back to this and discuss what it does and doesn't do, but it certainly helps the shape of the ridge. When we put a bone graft into the gap, and we put a temporary on, look at these numbers. That's not 1, that's 0.1. That's near 0. That's near 0, which is what I showed you a few cases already today.
At what stage?
This is at this is at the bone level. Let's look at the soft tissue level. This is 6 months. These are all 6 months out. I'm sorry, 6 months minimum out. Look at the tissue zone. This is the top 3 millimeters, 1, 2, and 3 millimeters up. 0.8 if we do nothing. 0.7 with the tissue being supported a little bit better. But if we do a graft with the temporary, 0.3. I can live with 0.3 and 0.7 and 0.5. I cannot live with 4, neither can you in the aesthetic zone. But under a millimeter, with the graft and a provisional, I'm seeing under a millimeter, and these are pretty strong numbers. So you can rest easy if you don't open a flap and you put an implant in, put a graft in and provisionalize as we showed you today, that you will have minimum changes. Okay, so the next step is if we put an implant in, we have a gap. Now, let's talk about this gap distance and what happens up against the implant with and without a graft, with and without anything, and with and without a flap is really, as you see, going to be the critical piece. So let's take a look at this and see where we are today with this concept. My thinking about this over the past 3 or 4 years has totally changed the way I do dentistry. I mean, it's completely modified almost what I do with an immediate socket, especially when the buccal plate is there. At this point, I had the idea, as you'll see, a while ago. Well, let's take a look at this case and then see where we are. When I put these 2 lower anterior implants in, out of the 4, I put these 2 micro minis, these 325 millimeter implants, and notice there's a gap here where the yellow line is. So the question is, what happens in there? Now, you've probably all heard this distance of 1.5 millimeters, the same 1.5 to 2, this horizontal gap distance, that if it's greater than 1.5 millimeter space between the bone and the implant, that you basically get a fibrous seam up against the implant. Have you all heard that general concept? Yes? Okay. How true is that or not? If you start looking at the data and looking at all the articles, again, as you know, as you've seen now, I'm a bit of a student of the literature, and as a teacher and as a clinician, to decide how I can be evidence-based with what I do. And when I went back and looked at the classic articles and I read through them again, and I went back as far back as '88, that no matter which implant was chosen, no matter which surface, although Botticelli had one article that implied that it was a bit different, no matter which surface, no matter what implant, you got even HA-coated implants in there, which are the best bone attractors. Yet, what did they all find? Every one of them found the same thing, that if the distance was greater than about 1.5 millimeters, they had a fibrous seam next to the implant, just like what you've been told. So therefore, don't leave a gap, or you need a membrane over the gap. So let's take a look at this, and I had some thoughts when I realized this, because take a look at Akimoto and Becker's article. They basically did exactly what others have done. They dentulated the animal, they put in implants with no space at the top, 0.5 millimeter gap, 1 millimeter gap, and 1.4, okay? And they locked the implant into the apical part so it would be stable and integrate. leaving this gap with a trephine open at different widths. You all see what they did? You all got it? Now, what did they do? What did they find? They found, just like you've been taught, that clinically they all looked okay, but histologically, look what happened. In the control, where there was no gap, the bone, which is red, came right up against the implant, which is what we'd expect. We got osseointegration. Now take a look at where there was 1.4 millimeter gap. What do you have in here? What do you have in there? That white stuff is connective tissue. The bone integrated down here. It's not a fibrous encapsulated implant. It integrated where there was bone at the apex, but where they had the gap is exactly what everybody's been saying. This is what the problem is. So, so why am I questioning that? I question it severely because it bothered me. It didn't make sense to me. One is that clinically, everything healed well if we leave the gap. But it bothered me histologically because when I went back and looked at these articles, what did they all do? They all opened the flap on an edentulous ridge, okay, a healed ridge. They made the openings, and then what did they do? When they got to this point, like right here, and they left the gaps, what did they do? They pulled the flaps over the top. Now, they deliberately did not put a membrane in. If you put a membrane in, all these would fill. If you put a membrane in, they would all fill. You're blocking the flap connective tissue from getting down and the epithelium. Now, if you don't, that's when you get this fibrous seam. So I said, wait a second. I said, but that's not what I did here. Let's go back to this case that I did. Let's go back to this case. This is the case that I just showed you. And this is what it looked like after 3 months of healing. I could not probe it, but what's up against the implant? Maybe it was just fibrous tissue instead of bone. That's the million-dollar question, isn't it? But here's the other question for you. What did I not do? What did I do differently than all those articles? I didn't pull the flap open. I didn't touch that tissue. I didn't pull the flap over the gap. So here's a different question for you. What if I let it heal like I did here by secondary intention, like any other socket? What's the wound healing like? And why did I say that should be different? Now, I said theoretically it should be different because the wound healing on an open socket is completely different than if you pull the flap over the top initially, or potentially, especially if there's an implant in the middle. And here's the final case. We got everything we need. By the way, this is a nice way to treat 4 lower anteriors. We published an article on this, and this is the standard way we do it in our office today. If the cuspids are not being touched, no crowns or anything, and we're taking the 4 lower anteriors out, which is pretty common. The cuspids are the last ones to go. We take out the 4 lower anteriors and we put 2 small diameter implants in. In these cases, it was the 3.25 millimeter implant. And we find that these work extremely well. Now, don't put 2 on the same side. People say, what if I put 2? No. Take the best socket on the left and take the best socket out of the 2 on the right. It's normally the laterals, interestingly enough, but take the best 2 sockets, 1 on each side, and out of those 4, you have enough support to support these implants. And we usually, even though if I could use a larger implant, I still use the 325s. Because you notice prosthetically, I'm not interfered with. It almost is interfering with my aesthetics already. Not that this is a big aesthetic zone, but I like to make a normal shaped tooth, not have the implant sticking in my papillar area, in between there. So we always do 325s, and they're more than strong. We've been doing this for, probably almost 8 or 9 years now. And we published on 10 consecutive cases like this, and believe it or not, we haven't lost 1 implant yet. But it's pretty believable. Why is it believable? This is a great area to do immediate sockets. Why? Because they're small diameter, number 1. Number 2, you have apical dense bone. This is the best bone in the body, so you're really locking into dense apical bone. Number 3, there's no nerve in the way. There's no violation of a nerve, so you can do 13s, 15s, 14s, 16s, whatever implants you want, whatever you're doing. You can go down and really engage the bone apically and not worry about any nerve penetration. And there's also some way, if the cuspid's not being touched, the aesthetics, you make it a little bit shorter, take it out of occlusion and tell the patient to stay away from it for the first 2 months. Then they can bite into anything. Okay, so there's no nerve. Aesthetically, it's not a critical area if you get a little recession, because it's a lower, and the bone is very dense, and it makes no more partials in these to replace this. No more. We don't put partials in anymore. This is what we do routinely. Okay, we stopped doing it years ago. Just as an aside. But let's go back to the sockets, though. Okay. Any questions about that before we move away from this? Let's go back to this wound healing. This is a critical thing for you to understand. If you take a tooth out, you get a clot. Now, the clot always is depicted in every diagram as this big, beefy, red, juicy clot, see? And every anatomist that makes a picture, every artist will make this big make a clot. Okay, there's red, it's blood. And that's fine, but that's okay initially. But it makes you feel like it's lively. It makes you feel like it's alive. When it's not alive, once that clot forms, you have dead red blood cells, and what else? Fibrin. That's all that's in there. So there's no blood vessels in there. So you got a void of blood vessels, and that's the important piece. So let's watch what happens. So my theory for years was, until this recent article that I published as a proof of principle, a proof of point, is that my theory was that epithelium and the connective tissue from the side cannot cross over here because it needs the blood vessels from underneath. See, let's take a look at what happens if, I always use the example, if I fell right now and I scraped my knee, and I had a 10 millimeter diameter cut, a bruise, 10 millimeters, I scraped myself. And first I bleed. Typical bleeding time is 8 minutes, so about 8 to 10 minutes later, I get a clot. Okay, then what happens? How fast will that re-epithelialize? What's the rate of epithelialization? About a half a millimeter to 1 millimeter a day from each side, from all the wound edge, from the other epithelial cells. So if I have a 10 millimeter diameter implant, a 10 millimeter diameter scrape, about how long will it take? Figuring 1 millimeter a day. Well, I have from both sides, so cut it in half. About 5 days, I'll give me a week, okay? So in a week's time, now here's an important piece. Does the epithelium go over or under the clot? Under? Over? Do I hear through? Politician says, well, I think it goes through the clot. It must go under the clot. Right. Now why? The clot's non-vascular. No blood vessels. So what happens? The epithelium, as great a material as it is and seals off our body so well, it doesn't have any blood vessels. Remember all those layers? Germinativum, spinosum, remember all those crazy layers? None of them have any what? None of them have any blood vessels. So epithelium needs blood vessels gets its nutrients by diffusion from the underlying connective tissue. So it's not going anywhere without what? Connective tissue. Now, and it's blood vessels. So it tries to cross over, but what's the difference between under here? It'll come underneath it, and then if you pull it off too quickly, if you take off the clot too quickly, what happens? It bleeds again, clots, and then does it again. So this will be about 5 to 7 days. Now, how long does it take for a socket to epithelialize in our bodies, in the mouth? Is it 7 days? It's about the same 8 millimeter opening. Conceptually, it should be 8 days, 5 days, a week. But it's not that. In fact, what's been shown, about how long does an epithelium take before, average-wise, closes over the top of our sockets? About 3 weeks is the average time. It could be it could be less, it could be more, but 3 is the average time. Amla went in 1962 and 69, actually did this in humans, and actually did biopsies in human extraction sockets and realized that the average socket took 3 weeks, not 1 week, which is what you might expect on the typical size wound. And why is it delayed? Because it can't cross over that clot. Now, it may try and go under, but there are new vessels coming out from the bone. By contact inhibition, will do what? Stop it from migrating down. So unless you had a dry socket where the clot is gone. But with the clot there, and it's protected, this cannot go across this. Why? There's no blood vessels in there. So it needs a support. So different than skin, where I have fresh blood vessels right under there, because of the tremendous depth of the defect of a socket, it can't cross over. You all got that? In fact, it stops. So what allows it to cross over eventually? The blood vessels coming out from here, the apex up, and from the sides will give it support. And as this comes in slowly to replace this clot, the new granulation tissue, young blood vessels that are pre-coated to form bone, come out from here, and this will not go any faster. It'll wait until this is forming, and this will go at the same rate. Got it? Okay. Well, that was my theory, and I've even spoken to one of my teachers, Sig Stahl, a great histopathologist. He says, Dennis, you're absolutely right. That cannot go any faster. You're absolutely right. What does that mean clinically? So this is a nice biology lesson, but what big deal? What's the big deal? And it is a big deal. Because we don't want to have a fiber seam next to an implant, because otherwise a little inflammation, it can unzip. So even though it looks good clinically, if you don't have bone on the front of that implant, it can really unzip if someone gets a little inflammation in the sulcus, you don't have bone there, and so the whole thing could unzip right to the point of real osseointegration. That's the risk of having a fiber seam 4, 5, 6 millimeters down. And I don't want to have that risk. But I said, what happens if we do this? So if you take a look at this, see the blood vessels come out, and this is still there, but it's not red anymore. In the mouth, it's not beefy red. What is it? It's yellowish. It's a yellow clot. It's fibrin. And so it sits there, and that's what happens. And this can't go any faster than these blood vessels coming into the clot. So this should really almost turn yellow by now, as you will see clinically. And so then it continues to heal. So when you look at this, and here's a chance to take a look at this. This is going to come in, and watch what happens here. It's going to come in, as you see here, and it's going to keep coming, and keep coming, and keep coming. And you see, that can't go any faster than that. Let me do that one more time. So it keeps coming. See how this is retarded here. It can't go any faster than the new blood vessels coming in and replacing the clot. And eventually it'll close it off after this comes in across. So this is the bone. This is new young granulation tissue that's pre-coated to form bone. Oh, got it? Got the concept? Okay. Now, what are we doing? We're putting an implant into the socket. So that's how a socket heals. So we're putting an implant into what a socket heals. So there's nothing unique about this. It's the same healing, but now if we don't pull the flap over the top, it's the same healing as a socket. But what's the difference? We're putting an implant in the middle of a healing socket. And that's what we're doing. If we don't pull the flap over the top, it should heal the same way. That's my theory. Now what should get to this implant first? If I pull the flap over, as all the research that before had done, if I pull the flap over with its blood supply attached in the flap, that connective tissue will migrate down there faster than this bone can come across. That will go down there much faster than this bone will come across. So that was my theory, that if we don't open a flap and leave it to heal by secondary intention, that this should in fact fill with bone, because that should get there first. All understood my theory? Okay. And that's what we did here. Now, this was just published a few months ago in the International Journal of Peri and Restorative Dentistry. And it's really, how many of you read this? Anybody? Some of you might have read it. I know some of the periodontists have. I think this is a proof of principle. It's a case report, but it's I think it's the fact that it can happen in a human, what you're going to see here, allows us to know that we can feel pretty comfortable doing this. Even though it's just one case report, it's a very special report. So let's go through this and show you what happened here. As part of a major case for this patient, Mr. Prolongo, we basically, Steve True and I were doing this case together in the office, and it was a serial extraction case. So we held on to this cuspid, even though we were going to eventually take it out. In the aesthetic zone, this would be a pontic. It's a maxillary cuspid. But I had 2 good implants in already, and I was going to just make this into a pontic, but we wanted to give him some extra support. So it was part of a major rehabilitation anyway, so I said, okay, let's put another implant in. And we did, not realizing that we might take it out. It wasn't our thought when we did this. But in doing so, look what we see. It's an unusually wide distance, isn't it? In fact, look at how wide this distance is from the buccal plate. That's 3 millimeters, that's 5. So it's over 4 millimeters, 4.2. Now, that's double what anybody else said was the minimum distance. Everybody else said anything up to 2 millimeters maximum, you got a fiber seam. Every article ever done, ever. Now, what you see here, Botticelli is the one that's a little bit closer, but he used some membranes in his articles too. Anyway, the point is that what you see here is 4.2 millimeters, twice the distance of the minimum gap distance allowable theoretically. All right, so let's keep going. So I said, boy, look at that. So I just put an end-coat abutment on. By the way, that's what an end-coat abutment looks like. And see these slots in here? That you don't have to take this off to take an impression. You just take an impression of this, and the technicians here, did they show you any end codes? Did they show you any of that? Well, this is what it looks like in the mouth. This is a standard abutment. This is an end code abutment. And these facets tells us exactly by where those facets are, and just taking an impression of that or scanning it will give them what? A readout of exactly where the hex is and also the height of this abutment. Tells them everything. And then they can make a custom abutment for you. Really kind of unique. Anyway, let's go back to the gap. So we went ahead, and we have this big distance. So theoretically, if my theory's right, what happens to this? If my theory's correct, Well, what's going to get to the implant first? The gap distance may not matter. The bone, the pre-coated bone right there should come out, and that should get to this through the clot first. This can't come down because it's away from the healing. So if my theory's right, we should get bone up against the implant, no matter what distance it is, as long as we don't pull the flap over the top. If you let it heal by secondary intention, just leave a clot in there and don't disturb it, that theoretically, my feeling is that we should get bone and not a long connective tissue or epithelium seam. Look at 1 week later. In 1 week, you see the soft tissue flopped over a little bit, but what's in there? There's the yellow clot. It's not red anymore. It's just fibrin. And then this is what it looks like at 6 weeks. Now, normally you'll be there at 3 weeks, but it takes 6 weeks to get the granulation tissue in because it was such a big distance to cross over. What's protecting the implant during this time? The clot. So people say, well, what's to prevent food from getting on the surface of the implant? The clot. What prevents food from getting into a socket, unless you had a dry socket? The clot. It's as simple as that. Let's not make it any more difficult than it has to be. The clot pulls right up onto it and it protects the surface. So the key is to not dislodge the clot, which is exactly what you tell the patient. What do you tell them if you just took a tooth out? Don't go near this area. No rinsing there for a few days. Exactly what you tell a patient if you just took out a tooth. Eat on the other side, soft diet, and don't brush or rinse up in this area for a few days. Life goes on. Now, by the way, what's interesting is we haven't seen a dry socket yet. I'm sure when I go back next week, you'll see a dry socket. But I've had dry sockets on regular extractions, but I haven't seen one with this. Why? We think it's because physically, if these are the threads of the implant, and here's the infrabony defect, the clot is physically locked in the threads, is one theory. The other secondary piece is we have texture. We got osteotype, we got whatever texture you got, and the fibrin locks into these blasted surfaces and etched surfaces so that we have a double whammy. As Jed Davies says, we have the contact osteogenesis combined with physically the threads of the implant made this stop the dislodgement of the clot. Anyway, this is what it looked like at 6 weeks. Normally that new blood vessels would show in 3 weeks. And here it is at 9 weeks. It's keratinized now, 12 weeks. And then Steve sculpted the tissue, as you see. He had a temporary on. And then at 5 months, we'd had to do the lower two, so we were doing other stuff. And then he was coming back to finish the top. And we took these pictures, and he said, Dan, remember this? And at first, we took this off. We sculpted this with an abutment, and we sculpted it looks like this. Now, there's no pocket depth here. That's what this looked like before. This is what it looked like. Now, some of the tissue moved in, of course. We lost a little bit there. We lost about a little over a millimeter. You'll see that in a minute. We measured this. But I need you to see that there's no pocket depth there, yet it was wide open with nothing in there, right? Nothing but a clot. So, from a wound healing perspective, what's up against that implant? So Steve, I had lost track of Mr. Polongo at this point. Steve was doing the prosthetics. I hadn't seen him for a few months. And he called me and he says, Dan, take a look. Remember Mr. Polongo? I said, yeah, but how's he doing? He said, he was the guy with that big gap. I said, oh yeah, how's it healing? And he showed me this. And I looked at him in the mouth. I looked at his mouth, and there was no probability. And I said, wow. I said, that's really beautiful. It shows, that conceptually, at least clinically, it looks great. The key is what? What's up against the implant there? That's the whole million-dollar question, isn't it? What's up against the implant, or do I just have a fibrous repair? And I said, he says, boy, wouldn't it be great to find out? I said, yeah, but we'd have to take the implant out. And he said, why don't we ask him? I said, that's a lot to ask a patient to take out a healthy implant, It's perfectly healthy, and we even finished the crown on it. And he says, well, it's really important to us as dentists. I said, yeah. He says, well, maybe we should ask him. And I said, well, I guess we can. It would be like a living gift. It's not wrong to do. And Steve, in his inevitable way, those Steve, he's the greatest guy. And he said, he's a nice man. He's a 76-year-old Italian guy, and a very pleasant man. And we did a lot for him. And he said, and maybe he'll let us do that. I said, well, it's worth asking. I went and spoke to ethicists. I spoke to lawyers. I took this very seriously. And basically, they said it's certainly fine as long as he has total informed consent and he understands what he's doing. It's like someone giving any part of their body up to help somebody, whatever it is. So it's certainly not unheard of, and it's not unethical to do as long as he understands everything and gives him informed consent. So I discussed it with him, and I said, whatever you have against this, only one tooth, but you have this so well documented that if we find out what's up against this tooth, and you're double the distance of the normal distance, that, to be honest with you, it would help us in dentistry a lot. if you let us take that out now. And the good news is, I know I have 2 healthy implants on either side. I can rebuild this bone and put another implant in, but let's say I can't even do that. The worst that's going to happen is you'll have a 3-unit bridge with a Pontic. All right, and I knew that. At least we had 2 healthy functional implants. It wasn't like I could not promise him something. And he said, if you think it's important, you guys have been great to me. He said, let's do it. I said, wait, I want you to come back 3 different times. We're going to go over it 3 different times. And he did. So, and he said, okay, then I got it. I appreciate it. I'll sign off for it and everything. And he did. And I said, listen, don't worry. I won't use your name or anything. And he's a little Italian guy. He says to me, he says, hey, what do you mean you're not going to use my name? I'll never forget that. I just laughed. And he's a wonderful, wonderful gentleman, a real gentleman, as you see. Anyway, so I want to give you the gift of a patient that Steve and I have. His name is Mr. Anthony Prolongo, and I hope you appreciate his gift. It's the Prolongo gap, right? It says. And so let's take a look at, this is the x-ray of that implant after 10 months now. It was 9 months here, but it was 10 months before we took it out. So remember, this was never covered. This was never covered. It had a healing abutment first, followed by an implant, followed by a crown that was fully loaded and complete. So this is what it looked like. And now look at the CAT scan we took. Now remember, it was 4 millimeters out. Remember, the 4.2. What distance do you see here from this distance that we measured? 3.1. So we lost, interestingly enough, about 1 millimeter of the buccal crest, not more. The rest filled in with bone. What's the million-dollar question? What's between the bone and the implant right in there? Got it? So we really only lost about 1 millimeter, even though this was unusually distended out. And here's the crown of what it looked like. And you can see we have a lovely crown. Everything was fine. So he let us take it out. And I took it out. As you see, I shouldn't have sounded it that day, but I did. I should, to see where the bone was, but I shouldn't have done that. But here's the new crown, just so you know, I did no harm to the man. He had minimum discomfort, and I built up the bone, as you see in here, and put a brand new implant in. And he's doing absolutely perfectly, and never needed anything else. Here's the implant. And what you see here is the buccal. Here's the lingual. And what you see here, let's go, this is a non-platform switch implant. It's a 3i osteotite implant. Actually, it was nanotite. But you take a look here. This was no platform switch, so where do we expect the bone to go down to? About? All right, so let's blow this up piece by piece. That's the buccal on the right. So this is the epithelium. Look at that. That's beautiful epithelium right up against the top of the implant. Here's where the crown was. And it was 10 months, remember, with an abutment here. And then another 5 months of an abutment, 5 months of a crown. And what you see here is beautiful epithelium. This is an artifact probably from my sounding it stupidly that day. And then here's beautiful connective tissue right up against the implant. Look at that. Beautiful connective tissue at the shoulder. And let's go down to the famous first thread. And there, ladies and gentlemen, is proof of principle. That's bone right up against the implant. That's only one case. But it shows, that this is worth more than all the animal histology altogether, no matter how good the animal histology is. Why? Because of the fact that it shows that in a human, it is possible, with good documentation, with histology, that we know exactly what happened, how it healed, and now we know have the histology. This is proof of principle that shows it's possible in a human being. It's not just an animal possibility, like someone who heals better than we do. So this is Mr. Prolongo's gift, and I think it's a great gift. This means that gap distance doesn't matter, in my mind. My theory, I believe, is correct. Because of wound healing, it makes sense. Now, how does this affect us? Well, it affects us a lot. It means that we don't have to worry about the gap. I don't have to pull flaps over it. Neither should you. It's the worst thing you could do. Pulling a flap over a socket now, over the gap, if you on an immediate, does so many violations. It opens a flap, that changes the buccal, bone dimension, as I showed you. You get, 4 millimeters of buccal lingual dimension change versus maybe only 1. You're also not going to pull the mucogingival junction down over the front of your tooth, in front of your implant. And most importantly, you're not going to get bone up against, if you don't put a membrane in, you're going to get fibrous tissue up against your implant, like all the research did in the animals. So why did I get bone here? Because I did not open a flap, and I let this heal by secondary intention. That's why. Yes?
So in the case that you showed earlier, where you did immediate placement with immediate...
The lower anteriors?
No, the maxillary central. And then you, after you fabricated the original, you put the bioass collagen in there.
Oh, that one, yeah. Mm-hmm.
Now that you know this, would you not place the bioass collagen in there?
Okay, then that's a separate question. Good question. She's my straight person here that leads me to my next question. So, Oh, look what how'd you know this was the next slide? Because what is this? Thank you so much. Should we put a graft in that? That brings the question of what does the graft do or what does it not do? Now, instinctively, most of you doing surgery know that if you have a gap there, you can't wait to put something in there, right? It just bothers you to leave it alone, right? You're as obsessive compulsive as I am, so I understand the feeling. You know, we're all in this together. Yeah, got to hold it. Give me some bone graft. Let's stick it in there, right? So the question is, what does it do, and what does it not do? Histologically, you must realize that that bone graft does anything special for you up against the implant. Let me say that again. Histologically, what's up against the implant is not determined by your graft. How about an infrabony defect? The periodontists know what happens with an infrabony defect. If you have an infrabony defect on a tooth and you pack bone in there without a membrane over it, what type of healing do you get? You get a long junction epithelium, don't you? Unless you put a membrane in to stop the flap connective tissue from migrating down. So here you pack the bone in really well into an infrabony defect on a tooth, and what happens? You get a long junction epithelium between the graft particles and the tooth, because the particles do not stop epithelium from migrating down. So this is no different. So if you pull a flap over your gap and think you've sealed it without a membrane, you're in trouble. If you put a membrane in, you got a bone regeneration. If you do not put it, but then you elevated the flap, which I don't want you to do. So if you let it heal by secondary intention, this exact diagram that you see here, whether it be with a healing abutment or with a crown, what does this graft do? Well, when the new vessels come in, is this going to change the wound healing? No. In fact, they might slow the healing up a little bit. Gets in the way because you have a clot. I need you to see this as not as a graft. It is a graft, but I need you to see it as what? From a wound healing perspective, I want you to see it as still a clot. From a wound healing perspective, it's still a clot that happens to have what? Particles in it. Then you understand it better. So my great teacher, Sigmund Stahl, who many of you know down here, and please say hello to him if any of you see Sig. Mark, do you see him every so often these days? I know I still have a picture of you and I and him together. You know, it was really great. Anyway, what does that bone graft do? Well, my first recollection of this was with Sig Stahl, and a great histopathologist, and who was my chairman of my department. And my craziness that you see is from Sig. All of my biology is from Sig Stahl. This is so you can thank him for driving you guys crazy today. You know, all he did was talk about biology. You know, but it affects our wound healing. It affects what we do, our decision making. So, and it affects literally what we're going to do clinically. So let's take a look at this. So let's say, I always like to use you as a bit of props. So let's say the tooth, let's say that wall is the implant, and you're the gap, and you're bone particles, okay? Now what does that make you? They're the gap, that's the implant. What are you? Right, you're the buccal bone. Okay, now look. Here we go. Excuse me, I have to take a walk. Excuse me. Okay, now listen to this carefully, because it's really very critical. You won't forget this now. Because the first time I learned this was I saw it when it was with infrabony defects. We used to do this with Sig, and he, myself, and Stu Fromm, we used to do this all the time when we were testing different bone graft materials on infrabony defects. And I said to Sig one day, I said, Sig, that's not my case. I said, what do you mean it's not your case? We did a mini block section on an infrabony defect on a tooth that was scheduled to come out. And we're looking at the histology together. And I'll never forget it, we were facing the two-way microscope, the teaching microscope. So he's showing me, he said, here's this. I said, Sig, this isn't my case. He says, yes, it is, it's Mr. So-and-so. I said, no, it's not. I said, those bone graft particles that we were testing, they're not up against the root. And he said, what do you mean? I said, they're not up against the root. Look, there's tissue between the bone graft particles and the tooth. And he says, well, of course it doesn't matter. That's what happens. He says, what do you mean? I said, Sig, I leaned on this. I'm telling you that I jammed those particles in. They were tight right up against the root. None of them are touching the root. It can't be my case. And he got up like this, and none of you know Sig, only Sig will do this. He gets up like this, and he reaches across, and he says, Dummkopf, and he calls me Dummkopf. Dummkopf, and he's German, and actually, he said, Dummkopf. He said, where did I go wrong? What did I do to deserve such a stupid student, and all this kind of stuff. I said, Sick, what you doing? He said, why'd you hit me in the head? He says, don't you understand? Those, they do nothing. They're just sitting there. I said, well, what are we doing here? So just listen to this. So here's what happens. You're the clot, but your particles, I jammed you in. I pushed on you. You're jammed into the opening, just like you see there. Got it? Now what's going to happen? We're the bone. Let's take a walk. Come on. Now, what are we? We're going to be the blood vessels coming from the bone, like new granulation tissue. Oh, you like him, huh? Okay. Do you know each other? I don't know. Oh, you do? Well, maybe you should be over here. All right, so now we're going to go through. Now, they're in our way, aren't they? Well, kick her out of the way. Kick him out of the way. Just go. Okay, darling. And our job is to get to that wall. He's a good blood vessel. Look at him. So we're going through the clot, but you're in the way. And what are you? Can you stop us? Certainly can't stop him. I can see that. You guys are even touching the wall. See, like you're touching that wall. That's the implant. Are you going to be able to stay there? You're in a clot. Now he's going to get to that wall, and what's he going to do? His job is to seal that off, and he's there. This guy, I got to take you on the road with me. His job is to get there, whether it be connective tissue or anything. He's there to seal off that implant from the outside world. And you against there, the bone particles don't stand the chance. He's going to move you. Thanks, buddy.
You're welcome.
What's your name?
Yeah.
What is it?
Jim.
Jim. Oh, Jim Cuso. Okay. Thanks, Jim. That's good. If I need a moving blood vessel, I know who to call. We're going to push you out of the way because you're basically dead. Look at you. Look at you. Especially after lunch. No, you're alive. But Jim just walked right through you, didn't he? And what could you do? You tumbled, you get rolled around, and you can't resist anything. You're just almost in the way. Now, what do you do, though? So what you can do is you might be able to, and this is what's interesting, what the research by Arojo and Lindy and our own data is starting to show, that with the graft, your shape of the ridge may be a little better. That this may not collapse in quite as much cosmetically. That's a few tenths of a millimeter, but that difference of that 5/10, 6/10 of a millimeter, that may be what you're doing. By both being incorporated into the free gingiva and the bone, we're seeing less collapse in. Histologically, though, what's up against the implant is not determined by you. Not at all. So, what does a graft do? It does not do anything except give the shape of the ridge potentially a little bit better shape. Simple as that. What's up against the implant is not determined by the graft that you put in there. Speed of it, if you have some fresh autogenous, the speed may be a little bit better. But the final product's the same. Bone or fibrous tissue or epithelium up against the implant, not the particles. Yes?
So if you take a case like the one we showed this morning where you had the implant addressed, or you just place the implant addressed and showing you put some bone graft
Yeah.
material and a membrane. If you didn't put the bone graft material, just put the membrane over.
Same healing, no problem. That is correct. This was done by Gottfredson. You can look that article up and as far back as 1992. He did exactly that. BioOS into the infrabony defect, BioOS by itself, BioOS with a membrane, and membrane by itself, and nothing. Without a membrane, they got a fibrous seam every single time, even with the BioOS into the opening. Without the membrane, you don't get the proper healing. Or in this case, we're doing this without a membrane. By keeping the epithelium and connective tissue on the outside, we're basically selectively allowing the bone tissue to come across first. The new granulation tissue from bone that's pre-coated to form bone to come across first. And that's really the whole story. Pritchard did this, right? Pritchard did this with the intrabony defects. Those are the periodontists. Certainly know John Pritchard, famous periodontist from Texas. And what did he do? When he had a deep three-wall defect, what did he do? Which is what we have here. He had a three-wall defect. He used to cut back the connective tissue and epithelium, did a gingivectomy. So the epithelium and connective tissue would be retarded and couldn't march down the tooth. It was before guided bone regeneration, and he found his best healing when he did that. So allow for cementogenesis to come up. And here it's bone. So do you understand what this graft does? This graft may help prevent the shape of this ridge from collapsing based on our research from moving in, but it does not change what's up against the implant. Yes? This was from a patient that had a sinus lift, and 3 years before, and to a simultaneous sinus lift, and here are the bone graft particles. Here's the bottom is the implant, and you can see the bone graft particles are not touching the implant. The bone is, and they're incorporated in bone. They're totally surrounded by bone, but they're not touching the implant. This is classic. You will never see this. You'll never see the bone particles up against the implant. It's really quite one of the more amazing things of wound healing that you'll ever see. Fascinating. Okay? I think it is. The bone, they can be inert, they can be surrounded by bone, but they're not up against the implant. So how does this affect our clinical healing? And I think this is an important piece that just starts to make a paradigm shift in the way I handle molars. If I have a type 1 defect where all the walls are present, Richard Smith, one of my partners, came up with this 3 different definitions. I expanded it with him a bit, but it was really his idea, and he deserves credit for it. We've submitted this for publication. Hopefully it'll be able to come out and, whenever it gets published in 6 months to a year. A type 1 defect on molars is where the implant is, the septum fully contains the implant body within its housing. In other words, that you're not in the extraction socket at all. You're in the septum of bone. You got all the stability you need, and you're in the septum of bone. Okay, it's called a type A. A type B is where the septum gives you stability, but part of the implant, like here, is in this remnant of the socket. Now, in the past, this would have been a nightmare. We didn't know what to do with this. Oh, we shouldn't do that. You got a big gap. It's bigger than 0.5 or 1 millimeter. You know, we shouldn't leave it like that. Even though the walls are here, this is only in type 1 defects where all the walls are still present. Today, I have no problem leaving this. And whether I fill it, what am I going to do if I put a bone in? Why am I putting the bone in? The bone would only be to help prevent this ridge, if it's in the aesthetic zone, like a maxillary first molar, from maybe collapsing in as much. Or it makes you feel better, put it in. It really is not a big significant piece if you have the buccal wall there. If it makes you feel better, put some bone in. But do not pull the flap over the top. Let this heal by secondary intention. That's the whole story. So a type B, the implant's stable from the septum bone, but part of the implant is sticking out into the remaining socket gap. Got it? And a type C, the septum wasn't strong enough or it got demolished when we put the implant in, and now we have to use the lateral walls for support. Remember, these are type 1 defects. Minimal to no septal bone with no stabilization from the septum, or it's wiped out. It's particularly true of second molars, where the roots are more fused and you don't always have a septum of bone. Or in the mandible, which is more common, because the bone is too thin to support the septum, to support the bone. So these are A, B, and C. Now, what's the significance here? Very plainly, these, particularly B's, I'm not worried about anymore. In terms of what the part that's partly in the socket, as long as the outside walls, the bony walls are there, and I don't hike the flap up, it doesn't bother me. This also brings up the topic of wider implants. This is exactly where we're going to go to wider implants. If we have stability, there's now adequate data, more than adequate, from multiple companies that show that if you have initial stabilization of at least over 30 to 35 Newton centimeters torque, you have the same high success rate of 95% success rate that you have on most other implants. So this, now that I'm not worried about the gap, if I can get 35 Newton to 40 Newton centimeters torque stability, I don't care what this gap size is and I don't care what the shape of it is, as long as the outside walls are still there. I mean, the buccal lingual walls are still there. Got it? So this is going to expedite our treatment for some of our patients. Now, I've spoken to 3i and others, and I said, get wider implants. You're up to 6, you should be at 7s and 8s also. Because some of the companies even go to 9s and 10s, as you know, and as we mentioned earlier. And I think that there is a place for these to be done this way. Now here I'm going laterally because I can't go apically. So I have to either engage the septum or I have to engage the lateral walls, and I have no problem doing that, and I'm not worried about the bone, the gaps anymore. Yes?
Where would you want to be in vertical placement?
Basically, that's a good question. We find that if we put it at the crest of the septal bone, assuming at a normal septal bone on a first molar, that's about 3 millimeters below the height of the free gingiva. So the septal bone is not a bad place to be, about flush with the septal bone or in that general vicinity. Because the normal furcal bone, if you look at the anatomy on Wheeler's textbook, the normal furcation is about 3 to 4 millimeters from the CEJ. I'll say that again. The furca entrance on a molar, on a first molar, is about 3 to 3.5 millimeters down and in. So that's almost the perfect place to give you a good emergence profile. So we find that if you at about the flush with the crest of these, that seems to be perfect. Okay? Is that it, sir? It's a good question. It gives you enough running room to come out and make a beautiful crown. So this is type C. So this is A, B, and C. You'll understand the difference. It's subtype A, B, and C. So here's a typical extraction socket. Just took the tooth out. We're going to go clean this out, of course, make sure everything's thorough. Now, this is a beautiful septum. When you trisect the root, as we showed you before, and take it out, you'll find more and more septums available to you. If you don't trisect them, you're going to find more and more septums not available there because you pulled it out with the teeth, especially since some of the curves are like this. So we always trisect and then pull them out. And this one is a perfect case to show this. Beautiful. This is a type A. Now, I want you to see this. This is 1 week later. Now the free gingiva kind of comes over the top. But look, see, there's the blood vessels coming in from the side. This is what a clot looks like. It's yellow. You've all seen it, but look carefully now. And this is a 1 week. See, the blood vessels aren't in there yet. They're coming in from the side, coming in. But to see, that's what the clot looks like. And look how it's protected all the way up on the abutment. There was no graft put in here. I need you to see that this is protecting all the way up, right up to near the height of the abutment, based on the position that you just asked me about, the vertical height. Very good. You all clear on that? Yes. I'm comfortable with any length that makes me stable, and that's when it brings up the width again, because we're going to go wider. Like the molars, I don't care if we're wider. And in fact, even if an 8.5 millimeter implant by 7 or 8 millimeters wide is going to be more than normal now, and especially with a platform switch. I mean, you go to 7s and 8s, you're going to have a platform switch that's beautiful. It's going to be bigger. It's great. Now, this is the immediate socket, okay? Now take a look at this molar. We can take this molar out. And it's this tooth here. It's got a crack and it's causing some problems. So we're going to take this out. Notice that we had to use a wider implant. So this was 6.5 millimeters wide. We went to the wider implant, bigger shoulders. Placed the implant in. It's 2 weeks. It's 3 months. You can see that we have a normal healing here. You can see we got the same bleeding because of the thick tissue that we always expect. And then we took our impressions. And here's the crown, screw down crown ready to be placed. And here you see the final crown with the bone right up to the edge of the platform, exactly what we'd expect. Nice, easy, one stop shopping, and you're done. Yes. Okay, so that brought me to this whole concept of this gap distance. And let's take a look at this case. This is a case with external resorption in here. You can see the resorption on the palate. And we spoke to the endodontist, and he said, it's all the way to the apex, just take it out. It's not worth trying to save. You can see the pus coming out and the symptomatic. And this is a nice, easy case, though, right? Because, look, thick, flat tissue, the buccal plate's intact. I mean, this is an easy case. I got everything I want here. Took the tooth out, placed the implant in, just as we discussed, up the palatal wall. And here, I didn't get the great stability that I thought I would have, so what did I do? I didn't want to put a temporary on. So what did I do? I said, okay, let me pack the bone in, put a healing abutment on, and let me pack the bone in. And I had some extra bone. This is what started me off on what I call the dual zone socket management. I had an extra bone. So, instead of just putting it in up to the crest, what did I do? I said, just for fun, I'm not going to survive all this stuff, but let me just see what happens. I had the extra bone anyway. What's the big deal? Okay, so I did that. And so I just put a flipper on right there. Marion Brown, one of my other partners, did the process on this case. So look what happens. See, at 2 weeks, you can see the particles are still trying to work their way out. The free gingiva is collapsed, but look how beautiful the bone is up here. That's really beautiful and not moved. The free gingiva, of course, has to come in and, to cover and try to seal this off. So this free gingiva, of course, because I did not put a temporary on to support it, is going to come in. And here it is. Notice this is at 3.5, 4 weeks. Look at the granulation tissue popping up, whereas it wasn't at 2 weeks. See that new blood vessels coming up? That looks good. That's what I like. And then, so this is what it looks like after 4 months. And then, now this is an interesting picture. And this is what gets me started. Marion then put pressure on the temporary. She put the temporary on and sculpted the tissue with pressure, blanched the tissue and created a nice smooth profile. So she got a nice emergence profile. Now what's that? This is the first case I did this supracrestal, bone grafting. And I said, Marion, look at that. I said, this doesn't bleed. I'm not sure what that is. Is it the bone particles that are caught in the free gingiva? Now I know that is that. But I didn't know that. This was years ago. This was the first case that I did with this kind of concept. And I said, boy, that's really weird. I said, is that good? Is it bad? Now, this was pretty thick tissue to begin with, so I don't know if that helped or did anything in the wrong. I don't know if I'm in the right shape here or not. You understand what I mean in this moment when I show you some other case. And here's the final case in place. I mean, everything looks great, but this was a pretty straightforward case. This was a piece of cake. Thick, flat tissue, and and here's the pre-op on the patient with the resorption, and here's the final case. And look, we even got a little extra tissue on this. I mean, these are so predictable. I mean, it's easy. So, but when I looked at that one picture stuck in my head, the free gingiva with that whitest stuff, I didn't know if that was bone. It just was kind of sitting there. No symptoms. So I came up with this concept called the dual zone socket management. And it's basically got two zones. There's the bone zone, everything apical to the crest, and of course the tissue zone. Now it sounds so simple, but basically some things will affect the bone zone and won't affect the tissue zone and vice versa, and some will affect both. So when I look at the variables, when I listed the variables on the bone zone, some of them we've discussed already, how thick is the buccal plate, of course, the size of the gap, the graft used, if any, did you put a flap or no flap, did you flap or not, did you platform switch or not, and the vertical and horizontal position of the implant. Those are the most obvious things for the bone zone. Now, some of them will affect the tissue zone, some are different. So let's go to the tissue zone. Did you place a provisional and support the tissue or not? Did you put a custom or stock abutment in? Was the biotype thick or thin? What was the buccal and vertical position of the implant, just like the other? Number of abutment changes, see? Now we understand that concept. You know, we might have only one abutment change would be okay. More than that, we lose it. Subgingival contour used to replace, and the texture of the abutment, all the things we've been talking about with what to do with the surface texture of an abutment. So these are totally different, except for a couple, than the bone zone. And this is a rather important thing that we have to do more studies on. Everybody's worked on the bone zone up till now. We're now looking, everybody is really full blast on the tissue zone. That's the next level of research, the texture of the abutments, how many times we take it off, the support structure, the shape of it. That's what it's all about. Because this is the last piece of finesse that we have to get, both for the midfacial tissue and mostly, believe it or not, for the papilla. So when you see, take a look at this case, I'll show you where we are today with this. It's similar to what I showed you before with the BioOS, but let's take a look at this case. She came in, and it's the first time we met the patient. She came in and was referred to us because his tooth was fractured, as you see here. So she had to have this out. Now, we talked about these, black triangles because she's got very narrow roots, narrow-shaped crowns, very tapered. So we spoke about that. But, she really doesn't have a papilla problem. She's got a black triangle, but why does it look like a papilla problem? It's because the contact point is too incisal. One of the easy ways to see if somebody has a papilla problem versus a contact point problem is what? Draw a line through all the papilla. And if they're all pretty much at the same line, there is no papilla problem, even though she's got a black triangle. That's a cute little way to do that, very simple way to look at it. Oh, you don't have a papilla problem. She's got a nice, pretty scalloped papilla. You have a contact point problem, and the easiest way to do this is what? A little bonding, obviously. Facings, a bonding. But she didn't want to hear about that. This is the first time we met her, and so she was a new patient to us, so she says, just do my front tooth. Because we already were looking at the final case. Do we want to duplicate this with a space? But she didn't want to hear that at that point. She did later. And now you know how we got here. Now you know how we got to this nice temporary. A straight cylinder with a shell. We join the two together, fill in the voids, and now you understand how we got this nice temporary, yes? And this is what it looks like. Now, so that's already done. I took a tooth, everything's done. And then I put the straight cylinder in, healing abutment, packed against it. Now this is Regeneros. So we packed it in there. This is the 3i Regeneros. It's small particle cancellous mineralized bone. And so when I take it out, notice how nicely it stacks right up against the straight abutment. I take that out, and the excess comes out. Looks like this, just like before. And now, because we had the temporary ready to go in. And this is the way the patient walks out that day. And here you see the bone graft and the implant that day. Here it is at 1 week. That's with the extraction and the fractured tooth. Interesting. Hardly any change 1 week later. Here it is 5 months. Huh? I'm sorry, I can't hear you. Shh. I use cancellous. I use cancellous because I like the sponginess of it, I like the open structure, and I can pack it and condense it nicely. Okay? But do we have that down for sure? I'll get to which bone graft in a minute. So you're one step ahead of me again. You two should know each other. Okay. Oh, maybe you do. I forgot. Okay. So, look at 5 months. What's the problem, guys? What do you need to know? What do you want to know about it? Is it okay? Okay, then you can keep talking. By the way, something I didn't show you, but you see this little bump there? When I did this case, there was this very small fistula at the top. I cleaned it out thoroughly, but it was a very small perforation with it was a fistula when she came in. And it sealed off completely by itself. I didn't just disregard it. Other than cleaning it out, I didn't disregard it. Cleaned it out from inside. I'll show you what happens in a moment if you can't do that. I'll give you another case. But I need you to see this. So this is Steve then convinced her to do some bonding to get this contour a little bit better. So she did some interdental bonding, as you see here, to get the contour while the temporary is still in there. And then we just go ahead and we're going to take this out. There's the temporary. And this is what we see. Now you see what's in here. Like before, we're not sure what that is. So we still weren't too sure. We'll come back to this again. And here's the final case in place. So you can see we got a beautiful result. Little bonding on the adjacent teeth just to get rid of the black triangle. The papilla was not the problem, and I think we got a beautiful case for the patient. So this is, very straightforward, and this is how we handle these cases. There's the before, and there's the after, okay? And there's the before, and there's the after. See the platform switch, the bone over the top, very classic. Yes?